Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome to SummaryCast.
Today, we're looking at a comprehensive review article from the March 2026 issue of the Korean Journal of Radiology. It's titled Photon Counting CT in Cardiovascular Imaging, Clinical Applications.
Right, and it tackles a frustration familiar to anyone reading cardiovascular CTs. You have a case with dense, heavily calcified coronary arteries.
And the images are just a mess of blooming artifacts. You can't confidently assess the degree of stenosis. It's a classic limitation of conventional CT technology.
So is this paper arguing that photon counting CT, or PCCT, is the solution to that problem?
That's the headline, yes. But it's not just about calcium. The authors position PCCT as a fundamental leap forward across a whole range of cardiovascular applications. At a high level, the technology itself is different.
How so?
Conventional scanners use what are called energy integrating detectors, or EIDs. Think of it like a scintillator that flashes when an X-ray photon hits it, and then a photodiode measures the total brightness of that flash.
So it's just measuring the total energy deposited, not the individual photon energies.
Precisely. All the nuanced energy information from the X-ray spectrum is lost. PCCT, on the other hand, uses a semiconductor detector, like cadmium telluride, that directly converts each X-ray photon into an electrical pulse.
And the pulse's height is proportional to that single photon's energy.
Exactly. It counts each individual photon and sorts it into an energy bin. It's a much more data-rich way of detecting X-rays.
Okay, so you get more information from the same X-ray beam. What does that buy you in practice? What's the first major benefit?
The first, and maybe the most visually dramatic, is ultra-high resolution, or UHR. Because PCCT detectors don't need the light-blocking septa that conventional detectors do, the individual detector elements can be much smaller.
How much smaller?
We're talking an in-plane spatial resolution of up to 0.11 millimeters. This is a huge jump.
And that directly addresses the calcium blooming problem.
Right. Blooming is largely a partial volume artifact from low spatial resolution. With UHR, you get much sharper definition of calcified plaques. The authors have a great comparison in Figure 2, showing a heavily calcified popliteal artery.
I see it. On the conventional EIDCT, the calcium bloom is so severe it's hard to see any lumen. It looks like a critical stenosis.
But on the PCCT image of the same patient, the plaque is sharply defined, the blooming is dramatically reduced, and you can clearly see the patent lumen. The stenosis is far less severe than it first appeared.
That's a big deal. That difference could change a clinical decision.
It absolutely could. The paper cites studies showing that PCCT reclassifies up to 54% of patients to a lower stenosis grade compared with EIDCT.
Wow. So that's the UHR piece. But you said it also captures energy information. That brings us to the multi-energy, or ME mode, right?
Yes, the multi-energy, or ME mode. Because the detector bins photons by energy, it can generate what are called virtual monoenergetic images, or VMIs. These are images reconstructed as if they were acquired with a perfectly single-energy X-ray beam.
And you can choose that energy level after the fact.
Correct, and you can use this to your advantage. For instance, high-energy VMIs, say above 100 keV, also help mitigate blooming and beam hardening artifacts from calcium and metal.
Okay, so you have two tools to fight calcium: UHR for better resolution and high-energy VMIs to reduce artifacts.
And a third, which is really clever, a three-material decomposition algorithm that can generate a virtual non-calcium image, which the paper refers to as VNCA, or pure lumen.
What does that do?
It identifies and subtracts the calcium signal from the image, essentially making the calcium appear gray instead of bright white. This makes the white, contrast-enhanced lumen stand out dramatically.
I see that in Figure 3. The calcium in the left main coronary artery is muted, and the lumen is much easier to assess.
It's another way to improve diagnostic confidence in these challenging cases.
So if it works this well on calcium, I have to assume it's the same story for coronary stents.
Exactly. Stent evaluation is another major challenge because of beam hardening and blooming from the metal struts. PCCT's UHR mode provides a much clearer view of the stent architecture and, more importantly, the lumen inside it.
allowing for better assessment of in-stent restenosis.
Right. The paper points to several studies showing PCCT has better diagnostic accuracy for this. Figure 4 has a striking example of a renal artery stent. On the conventional image, it's a blurry, bright artifact. On the PCCT image, you can almost count the individual struts.
That's impressive. The luminal assessment is clearly improved. Okay, what about visualizing things that are just natively very small, not just obscured by artifact?
Another area where UHR shines. The article mentions improved visualization of small coronary side branches, which could be important for future updates to reporting guidelines like CAD-RATs.
Beyond the heart?
Yes, things like the digital arteries in the hand for evaluating scleroderma or small perforator arteries for reconstructive surgery planning. The paper even notes it helps with reliably identifying the artery of Adamkiewicz, which is critical for spinal cord perfusion during aortic surgery.
And often very difficult to find on conventional CT.
It is. This improved visualization of small vessels is a recurring theme.
Let's talk about the other side of the spectral coin. We've discussed high-energy VMIs. What about low-energy?
Low-energy VMIs, like those at 40 or 50 keV, are set closer to the K-edge of iodine. This makes the iodine in the contrast appear much brighter, dramatically increasing the contrast-to-noise ratio.
So that has two potential benefits. You could either get better images with a standard contrast dose, or
get diagnostic images with a much lower contrast dose. This is a huge advantage for patients with renal dysfunction.
you could salvage a suboptimal study.
Precisely. Figure 6 is a perfect illustration of this. It shows a CTA where contrast extravasated, leading to very poor aortic opacification, a mean of 191 Hounsfield units.
A non-diagnostic scan, basically. You'd have to repeat it.
On a conventional scanner, yes, but with PCCT, they just reprocessed the data to create a 50 keV VMI. The mean attenuation jumped to 450 HU. The aorta is brilliantly opacified. The scan is saved, and the patient avoids a second dose of radiation and contrast.
That's a very practical real-world benefit. Okay, so we've covered anatomy, vessels, calcium, stents. What about physiology or tissue characterization?
The improved spectral performance carries over there too. It enhances myocardial perfusion imaging, late iodine enhancement for detecting myocardial scars, and extracellular volume, or ECV, quantification.
All with better image quality and lower noise than what's possible with EIDCT.
That's right. The paper also touches on plaque characterization. With UHR, you get a better look at the vessel wall and the components of atherosclerotic plaque.
You mean identifying high-risk features?
Yes, like a low attenuation lipid core, which is associated with a higher risk of rupture. Figure 7 shows a non-calcified plaque where the PCCT image provides a much clearer delineation of that central lipid core compared to the conventional CT.
So it could become a more powerful tool for risk stratification.
That's the potential. And the spectral aspect helps with characterizing other things too. For instance, using iodine maps to differentiate a thrombus which has no iodine from a slow-flow artifact or tumor which would have some iodine uptake.
Okay, that makes sense. It's essentially direct material quantification.
It is. And this leads to another major benefit, radiation dose reduction.
I was waiting for this. All these advanced features, UHR, spectral reconstructions, it feels like they must come with a higher radiation dose.
Intuitively, you'd think so, but PCCT offers several clever ways to lower the dose. The most straightforward is by making the pre-contrast scan unnecessary in many cases.
You mean for coronary artery calcium scoring, the CACS scan?
Right. Instead of a separate true non-contrast acquisition, you can perform a single contrast-enhanced CTA and then generate a virtual non-contrast, or VNC, image from that dataset to calculate the calcium score.
So one scan instead of two.
Correct. This is particularly valuable in multiphasic studies, like for post-endovascular aortic repair, or EVAR, surveillance.
Which is a known high-dose examination. It's typically a three-phase protocol, non-contrast, arterial, and delayed.
Exactly. The non-contrast is needed to distinguish pre-existing calcification from a new, active endoleak.
With PCCT, the paper lays out two dose-saving strategies. The first is a biphasic protocol.
2 phases instead of 3?
Right. You do the arterial and delayed phases, but you skip the true non-contrast scan at the beginning. You can generate a VNC from the arterial phase data instead.
Got it. So that cuts the dose by about 1/3.
It does. But the second strategy is even more efficient, a single-phase protocol.
Wait, just one scan? How do you get all the necessary information?
It's a really neat application of the technology. You acquire only a single delayed phase scan.
But that means you lose the arterial phase, which is critical for assessing the stent graft and seeing certain types of endoleaks.
This is where the low-energy VMI comes back in. From that single delayed acquisition, you can generate a VNC to serve as your non-contrast series. And you can also reconstruct a low-energy VMI that boosts the iodine signal so much that it effectively creates a virtual arterial phase image.
That's remarkable. So one acquisition provides data sets that functionally replace all 3 conventional phases.
That's the concept. The authors cite a study suggesting this allows for a protocol with just 1/3 of the radiation dose of a traditional triphasic study.
That's a massive reduction. Okay, this technology sounds incredibly powerful, but nothing is perfect. What's the catch? The paper must discuss the challenges.
It does, and they're significant. Table 3 lays them out quite clearly. The first and most obvious is cost. These scanners are substantially more expensive than conventional high-end CTs.
That's a major barrier to adoption.
For sure. Then there's a steep learning curve. We've talked about all these new parameters: UHR mode, ME mode, different kernels, iterative reconstruction strengths, slice thicknesses, matrices. It's not a plug-and-play system. It requires a lot of technical expertise to optimize protocols.
And you mentioned UHR gives better resolution. Does it have a downside?
It does. Noise. The high spatial resolution of UHR mode comes at the expense of higher image noise. You can see this clearly in Figure 12. The sharper reconstruction kernel leads to a grainier image.
So UHR mode might not be suitable for all patients.
Correct. It's particularly challenging in larger patients where noise is already a problem. You have to select patients carefully. The standard resolution ME mode is often a better choice for them.
What other practical hurdles are there?
Collimation. The UHR modes use a smaller detector collimation, which means a longer scan time is needed to cover the same anatomy. This increases the chance of motion artifacts and requires adjustments to contrast injection protocols.
And what about the data footprint? UHR means thinner slices, and ME means multiple reconstructed series. That sounds like a data nightmare.
It is. The amount of data generated by a single PCCT study can be enormous. This has major implications for data transfer times from the scanner to PACS and for long-term storage.
So the hospital's IT infrastructure has to be ready for it.
Absolutely. It's a real-world practical bottleneck that can delay final reporting and has significant financial implications for data storage.
So putting it all together, what's the final verdict from this review?
The verdict is that PCCT represents a paradigm shift in cardiovascular CT. It's not just an incremental improvement. The gains in spatial resolution and spectral information are solving real, long-standing clinical problems, especially in the assessment of calcified vessels and stents.
But it's not a simple one-for-one replacement for current scanners.
Not at all. It's a more complex, powerful tool that comes with a new set of rules and challenges. The authors make it clear that optimal use requires a deep understanding of its technical parameters to tailor scans for specific clinical questions.
And the latest scanners are now offering combined modes, UHR and ME at the same time.
Yes, which is another layer of complexity and power. It allows for the simultaneous acquisition of both ultra-high-resolution anatomical images and multi-energy spectral data.
Okay, bottom line, this is a major technological leap, particularly for challenging cardiovascular cases. It improves diagnostic accuracy and can lower radiation and contrast dose. But the implementation hurdles, cost, the learning curve, noise in some modes, and massive data loads are non-trivial.
You nailed it. It's an incredibly promising technology that demands a new level of expertise from the teams using it.
A powerful tool, but one with a detailed instruction manual. And that's our summary.
Thanks for listening to SummaryCast.